In this presentation, we're going to discuss using the Berwick model to improve pain perception scores in children. The Big Bang Children's Medical Center, or BBCMC, is a 187-bed institution that serves pediatric patients locally, nationwide, and internationally. They offer services in medical, surgical, transplant, and specialty care. So our problem was that patient and parent satisfaction on the perception of their pain treatment during hospitalization decreased from the 90th percentile to the 40th percentile. And so a pain management team, or PMT, was formed to improve these pain satisfaction scores. The co-directors of the PMT are Penny, who's a clinical nurse specialist, and Dr. Leonard Hofstetter, who's a pediatric anesthesiologist. Our group used the Berwick model in order to develop a plan. So the Berwick model follows a plan, do, study, act format, which ultimately you plan a change, complete the change, evaluate that change, and then act on what is learned from the evaluation. So in planning, you're forming the team, setting aims, establishing measures, and selecting changes. When you're doing, you are testing those changes. During the study portion, you evaluate your results and then make changes based on the changes that you would tested. And then acting, you implement changes to other units and spread changes hospital-wide. So a solid work plan was implemented with the goal of increasing pain management perception scores in patients hospitalized in the BBCMC unit to the 90th percentile by January 1st, 2020, and this was using the Berwick model. So this is just a quick overview, and we'll dive deeper into this in the work plan. But the pain management team was created with different specialists from a variety of backgrounds and expertise. The team ultimately implemented patient-controlled analgesia, or PCA, in all patients aged 5 years and older. And then the pain perception scores were reviewed monthly, and the data trends were evaluated quarterly.
Work plan. The work plan focused around the IHI Berwick module for improvement as the framework to successfully implement the intervention. Each step of the plan focused on what we were trying to accomplish, how we will know that a change is an improvement, and what change can we make that will result in improvement. We plan to develop an action plan focused on the implementation of the patient-controlled analgesia PCA pumps. We next focused on implementing the PCA pumps into the units for 2 months while recording data and evaluating those results. Then we studied those results for patient satisfaction. Lastly, we continued trialed interventions on other floors for effectiveness and successfulness. Each step outlined the team members who would be responsible for each step, a realistic timeline, resources that were available and needed, along with potential barriers, and the overall communication plan throughout the steps. Step 1, co-directors of the pain management team, PMT, focused on gathering the needed nursing staff, a 40-bed surgical orthopedic unit, along with the available pharmacy staff. Monthly meetings were held to discuss the ease of transition to implementation. Step 2. Everyone involved worked to use the data collected and other research to implement a successful plan. Although some individuals were hesitant about the implementation of the PCA pumps, the PMT worked to train, educate, and develop a protocol for implementation. Step 3. The PMT used team members and data to create a questionnaire and staff to monitor results. The hesitation of the parents, patients, and medical teams were potential barriers, but the PMT discussed reported pain scores monthly to address progress. Step 4. Co-directors used self-reported scores and evaluated successfulness in order to address the effectiveness of collection and analyzation of the scores. The PMT did quarterly evaluations. Step 5. PMT used all collected data and implemented the PCA pumps with needed modifications for additional units in the hospital. The PMT will continue to use Berwick's module to ensure successful implementation to each floor. The evaluation process focused around the patient's self-reported pain scores and were evaluated at the 2nd and 5th months. Evidence of success were determined by the unit's current ranking being consistent with the hospital's previous benchmark ranking. By the first quarter, the score will rank in the 60th percentile. By the second quarter, ranking will be in the 90th percentile or above. The plan was organized and monthly meetings were held to discuss the progress, barriers, and any questions or concerns. All team members were on board and worked successfully to have the plan implemented to the floor. The PCA pumps were implemented into the unit and records were accurately kept. As the PCA pumps were implemented, it was evaluated that the pain scores began to decrease at each monthly meeting. The trial interventions on the other floors were successful, and there has been a decrease in the pain perceptions of patients across the hospital.
Outcome. Plan. Forming the team, setting aims, establishing measures, selecting changes. Training in PCA use. Once the pain management team has been created, required patient control analgesia training through interprofessional education will take place for team members between June 11th through June 30th. Starting July 1st, Penny and Dr. Hosfersatter will collaborate and perform an in-service on PCA usage to the floor staff. Nursing staff will be informed ahead of time via email to attend one of the in-services provided twice a week at 5 a.m. or 5 p.m. By July 4th, all staff should now be ready for implementation of the PCAs. Outcome continued. Do. Testing changes. Distribute PCAs on the surgical/orthopedic unit. Amy Fowler will implement the intervention on the unit July 5th for 2 months. Catered monthly lunches will be provided as an incentive to continue assisting the pain management team with lowering pain perception. Patient's pain perception will be assessed every 2 hours by the nursing staff. This will be documented in the Epic charting system for further evaluation. Self-reported pain will be evaluated through a questionnaire populated through a patient's television every 4 hours. If patient needs help completing the survey, discuss with the parent or guardian available, and advise patient to contact staff for further assistance. Nursing staff will provide a discharge survey created by Bernadette Roskowski that allows the patients to rate how satisfied they feel their pain was handled during their stay. PCA usage by the end of the 2 months should be at a 95% or higher. Self-reported pain perception is 6 or lower by the 2nd month of implementation. Outcome continued. Study. Evaluate the results. Starting September 9th, Penny will lead monthly staff meetings every 2nd Tuesday of the month to discuss self-reported pain scores collected from the 3 sources of evaluation. Surveys will be distributed to staff at this time via email by Raj Kathrapali to establish if the interprofessional collaboration and education is at least 85% effective. After 2 months of implementation and evaluated results, pain perception on a 0 to 10 pain scale has decreased from an 8 to a 5 for patients following any medical services. Final outcome. Act. Implementing and spreading changes. After a successful 2-month implementation period, self-reported pain perception decreased by 37%. As a result, Chief Medical Officer Dr. Stuart Bloom will initiate PCA usage on an additional unit. Advancing the project to another unit will determine the project's effectiveness and potential to be implemented hospital-wide. With continued observation and evaluation of PCA usage on the surgical/orthopedic unit, BBCMC will increase pain management perception scores in patients hospitalized on this unit to the 90th percentile by January 1st, 2020 by implementing patient-controlled analgesia.
Advocacy. Nursing advocacy has 3 main components: protecting patient autonomy, advocating for your patients, and promoting social justice. Advocacy continued. The first component of nursing advocacy is protecting patient autonomy. Penny, the co-director of the PMP and clinical nurse specialist, sees that the children are experiencing pain and wants to protect their right to make decisions about their pain management treatment without the influence of other care providers. According to the Berwick module, Penny is a leader and is the one to start the change she wants to see and is ready to face opposition from others at the hospital. The second component of nursing advocacy is advocating for your patients. Other members of the PNT, such as Amy Farrah Fowler, a charge nurse and acting manager on the surgical and orthopedic floor. She has advocated for patients and has been successful in treating pain in her unit. Based on the WearWork module, Amy is an early adopter, since she has experience in having helped her unit in treating pain successfully. Amy has the experience in dealing with other providers on her unit and was able to change their minds to follow a protocol to treat pain successfully in children. The third and last component of nursing advocacy is promoting social justice. Everyone in the PMT are trying to incorporate a change to reform their institution. BBCMC is a top 10 nationally ranked institution serving children and has a strong portfolio to expand their change in treating pain in children into other institutions once successful. According to the Berwick module, this demonstrates investment in the team's time and the energy needed to create positive change.
So overall, the Berwick model was a very effective model for us to base this work plan off of. It had clear and easy to follow formatting. It was very well designed for small tests of change that were performed within individual hospital units and then spreading that to additional units throughout the hospital. And there was the ability to adjust the model as we needed throughout the work plan. The limitations of this model are that there aren't many tools included for interprofessional collaboration and education, so that is something to be aware of when moving forward into this work plan, is that you have to bring that to the table separately. So the next steps of this work plan are really about implementing changes in additional units and then spreading those changes hospital-wide. We spoke about this a little earlier, but within 2 months, enough information will be gathered from the scores of patients on the surgical and orthopedic floors to establish if the change that we are implementing has been effective. So within those 2 months, we should see at least a 20% increase in our pain satisfaction scores. After achieving that goal outcome, that work plan can then be implemented on medical floors and further evaluated to see if we are seeing the same results with this work plan on another floor. So by January 1st, 2020, after a successful implementation in the surgical, orthopedic, and medical floors, which we see as a greater than 90% satisfaction scores on pain perception, the work plan will then be implemented hospital-wide. Due to the extensive modifications that we made during the planning phase of the work plan, it is anticipated that implementing this same work plan in the same hospital on a different unit will still produce similar results. However, thankfully, due to the Berwick model, we have this ability to test our changes, evaluate the results, and then make changes accordingly. So, should the implementation of this same work plan have varying results on other units, we will be able to do an investigation into those contributive factors and then hopefully control some of those contributive factors to obtain some of those similar results that we were seeing prior. So we've seen that cooperation and participation from the entire patient care team is an essential component of any work plan. As it's not something that's emphasized by the Berwick model, extra care and consideration must be taken to ensure that interprofessional collaboration and education is integrated into the work plan. Implementing interprofessional education prior to the initiation of the test of change increases workplace cooperation and unit-wide receptivity. So in conclusion, despite the limitations of the Berwick model, it is still an effective tool to increase pain management perception scores within a hospital setting. This model accounts for the need to constantly adjust the work plan as required in response to incoming information from the study. The adaptivity of the Berwick model ensures that we produce the best possible outcomes for our patients. Should you need any references, you'll find them here. Thank you very much for listening to our presentation.